Hi, everyone. Thank you again for joining us. If you were not on the earlier sessions, my name is Erin Foley, and I am co-president of the National Adrenal Diseases Foundation Board of Directors. I am your moderator today, and I am pleased to introduce our next speaker, Dr. Lindenberg, who is the Chief of Nuclear Medicine in Molecular Imaging at the Center for Cancer Research of the National Cancer Institute. And we are very pleased to have her here today, not in representing the National Cancer Institute, but of her own accord on her own time. She is going to be talking with us about PET imaging and for adrenal adenomas, so adrenal tumors. And with that, I'll let you take it away, Dr. Lindenberg.
Thank you so much, Erin, and I really appreciate the opportunity to come and speak to your audience. So I thought that we would do a little bit of some basics, such as what is a PET scan? So many people might think this comes to mind, which isn't too far, but positron emission tomography is actually scanning, which is one of the most frequently used molecular imaging procedures. PET provides detailed pictures of what is happening inside the body at the molecular and cellular level, where other diagnostic imaging procedures such as X-rays, CT, and ultrasound predominantly offer anatomic pictures. Molecular imaging allows physicians to see how the body is functioning and to measure its chemical and biological processes. Molecular imaging offers unique insights into the human body that enable physicians to personalize patient care from diagnosis, assessing to treatment, and monitoring disease. And PET-CT scanning is non-invasive, safe, and painless. So what we do with PET is we use the radiotracer principle. A radionuclide, which is typically something like F18 or gallium-68, is added and combined with a targeting vector, which is the binding molecule. But to combine the radionuclide with a targeting vector without reducing its affinity to its target, normally linking structures such as a linker molecule are necessary. Then the binding molecule or the target vector is attached. And then in the body, the targeting vector guides the radiopharmaceutical to its specific target, which is the receptors. And that is useful in terms of our imaging. So PET involves a radiotracer like what we just saw there, the molecular aspect to it, and it's injected into the patient's bloodstream. Once the radiotracer accumulates in the body's tissues and organs, its natural decay includes emission of tiny particles called positrons that react with electrons in the body. This reaction produces energy in the form of a pair of photons. The PET scanner, which is able to detect these photons, creates the three-dimensional images that show how the radiotracer is distributed in the area of the body being studied. So here are 4 unique radiotracers that depict different functional diseases based on particular molecular targets. So we are interested in Ga-PentixaFor 68, gallium-68 pentixafor, which is the radiotracer, and we'll talk a little bit more about it. It's an analog to CXCL12, which is a chemokine, and it binds very strongly to the CXCR4, which is a chemokine receptor. There are many preclinical and clinical studies that have been done on this radiotracer. Most importantly is that over 1,000 human scans have been done with this tracer, and there are no adverse events or safety issues with that. So what are chemokines and chemokine receptors? They belong to a superfamily of cytokines. They're small proteins, and these proteins, when they bind to each other, they act as a traffic cop for cell migration and localization. They're produced by immune cells, endothelial cells, as well as tumors. They have 4 different classes, and we're interested in the CXC class. And there are currently 50 human chemokines that are known with 20 receptors. Ga-PentixaFor is a radioactive element. As such, there is radiation that is emitted into the body, but this is actually not a high dose as you would get with radiation therapy. It's actually very, very moderate. It has excretion like many other tracers as a kidney and bladder excretion. So you'll see that in these images, which are spanning from 4 minutes to 4 hours. Typically, the best images are obtained at 60 minutes plus or minus. So Ga-PentixaFor is targeting CXCR4. When it does, it will actually start a cascade of signaling pathways involving cell migration, proliferation, homeostasis, and others in normal and tumor tissues. CXCR4 has been seen to be expressed very highly on aldosterone-producing adenomas, cortisol-producing adenomas, as well as ACTH-producing pituitary adenomas. But significantly, it is not in non-functioning adenomas. And we'll also talk a little bit more about this. But what's significant to remember is that localizing these functional adenomas is important for managing treatment options. Current imaging modalities are either too invasive or insufficiently able to differentiate adrenal conditions. So that brings me to primary aldosteronism. So aldosterone is a mineralocorticoid hormone involved in maintaining the homeostasis of extracellular volume, blood pressure, and potassium levels with mediation through the renin-angiotensin pathways. Primary aldosteronism is dysregulated aldosterone production. The prevalence is approximately 11% in normotensive individuals and up to 22% in hypertensive people. This is an under-recognized common cause of secondary hypertension with implications for cardiovascular, renal, and metabolic morbidity and mortality. Diagnosis can be challenging due to invasive procedures. There are several subtypes, as you can see on the slide. This is a graphic from one of the first studies looking at Ga-PentixaFor in adrenal adenomas. They found increased uptake corresponding to CXCR4 expression and were able to assess which side was likely responsible for aldosteronism through visualization and uptake ratios. Studies have also made publications that show that tissue specimens can demonstrate high binding to the tracer, and CXCR4 expression has been seen in normal adrenals, highly seen in the aldosterone-producing adenomas, and even the adrenal cortical carcinomas, but not in the non-functioning adenomas. Below in the image, you can see there is focal uptake in adenomas on the patient level. And here, this describes the performance of PentixaFor in patients with adrenal cortical nodules. The top is the aldosterone-producing adenoma with high expression to help determine which adrenal gland is producing the problems, so that surgically that might be the one to go after. Cortisol-producing adenomas also show uptake, but like we mentioned before, the non-functioning adenomas are not showing uptake, and neither is the iatrogenic, but the idiopathic adrenal hyperplasia. That's very significant and helpful in distinguishing what type of disease process is going on. Here are some dynamic imaging in patients who have active adenomas, the aldosterone-producing adenoma, and the inactive adenomas. And you can see there is significantly increased uptake versus the areas, the tissue that is not diseased. So adrenal venous sampling aims to localize the aldosterone excess based on hormonal measurements directly from the adrenal veins. Although adrenal venous sampling is conceptually viewed as the gold standard for establishing the source of aldosterone excess, this procedure is poorly harmonized between referral centers around the world. And so the same patient may receive conflicting advice based on where it was done. Having our radio tracer that is non-invasive can make the whole process much more seamless. And these researchers did a prospective study on 100 patients who were also going to undergo adrenal venous sampling and had primary aldosteronism. And they found that the Ga-PentixaFor PET-CT was concordant with adrenal venous sampling 90%, which is really very high. They did state that in small, tiny lesions less than a centimeter, the PET-CT Ga-PentixaFor was not as helpful in identifying that disease. Here is an example of two patients, one who has unilateral and one bilateral primary aldosteronism. And it shows that uptake is seen very nicely in both sides, which is very helpful in terms of managing the patient's treatment process. So Cushing syndrome is another adrenal disorder that we're looking at. And the incidence of overt Cushing syndrome, which is the classical hypercortisolism, is low, affecting about 10 to 15 per million people annually, but often also underdiagnosed, and the true incidence is likely higher than reported. Subclinical hypercortisolism, which is the excess cortisol without classic signs, is more common, and it's found in up to 2% of the elderly population, and higher rates in those with conditions like difficult to control type 2 diabetes, resistant hypertension, or adrenal incidentalomas. So this discrepancy highlights the importance of screening for hypercortisolism in patients with specific risk factors. Cushing syndrome may be caused by excessive ACTH secretion from a pituitary or non-pituitary ACTH secreting tumor, which drives the adrenal cortisol production, also known as ACTH dependent. The optimal strategy for detecting ectopic ACTH secreting tumors has not been defined. There is also the ACTH independent or autonomous adrenal secretion of excessive amounts of cortisol, which is not stimulated by ACTH. And adrenal tumors comprise 20% of this, and that can be seen in adrenal carcinoma or in adenomas. A low plasma corticotropin concentration in a hypercortisolemic patient is evidence of ACTH independent disease. Other rare causes of ACTH independent disease are things such as bilateral macronodular adrenal hyperplasia and primary pigmented nodular adrenocortical disease. These are representative Ga-PentixaFor images showing different manifestations of Cushing syndrome. Here we have a cortisol-producing adrenal adenoma where the pituitary gland does not show uptake, but you can see it very strikingly by the arrow on the left side of the adrenal. Then there is the macronodular adrenal hyperplasia. which is ACTH independent. And here again, the pituitary is not showing focal uptake, but you're seeing the hyperplasia bilaterally. Then there is the non-functioning adrenal adenoma, which again does not show any uptake in the pituitary or within the adrenals. The classic Cushing's disease, you will see uptake in the pituitary gland and also see its downstream effects in the adrenals. This one is interesting because this is the ectopic ACTH syndrome, where this patient actually had a rare thymic carcinoid tumor removed, and you can see a lot of uptake corresponding to metastasis, which are driving the production of the cortisol in the adrenals. And here again, you can see that a non-functioning adenoma, this time in the pituitary, does not show uptake in the pituitary or in the adrenal glands. That brings me to the study that we have now going on at National Cancer Institute, which is a phase 2 study evaluating the functional status of the adrenal glands with Ga-PentixaFor in hyperaldosteronism and hypercortisolism. So the main inclusion criteria we're looking for is to have a patient who has one or more adrenal masses on CT and or MRI with biochemical evidence of excess aldosterone or evidence for ACTH dependent or independent hypercortisolism with or without adrenal enlargement. And they must be willing to undergo adenoma resection if warranted. Our objectives are really to estimate the percent concordance of imaging with clinical diagnosis in identifying functional adrenal or extra-adrenal adenomas. And participants will also be screened and evaluated by our expert endocrinology team led by Dr. Lynette Neiman. So in our study schema, this is a pilot single-site 3-arm study where subjects are enrolled into one arm according to their probable disease, which would be primary aldosteronism for arm 1, ACTH independent Cushing syndrome for arm 2, or ACTH dependent Cushing syndrome, arm 3. All participants will undergo one baseline Ga-PentixaFor PET-CT or PET-MR scan. Patients will then have further endocrine investigations, adrenal venous sampling, or additional imaging performed under a different NIH protocol. So far, we've had about 10 patients on our study, and I just wanted to highlight a few of them. This particular individual had hyperaldosteronism and small right adrenal lesion, as well as left adrenal thickening. Our images show that it seems that both sides are picking up Ga-PentixaFor. He has not yet gone through his ABS, so we will have to see if that corresponds to what we're seeing on imaging. This is an interesting patient who had hypercortisolism, and you can see focal uptake in the right adrenal mass, and there was also a left adrenal nodule, but there was no uptake there. When this patient went to surgery, it did confirm that there was macronodular adrenocortical disease on the right. In this patient, this person had pituitary doesn't have any focal uptake, and there was concern for ectopic ACTH secreting lung nodule at the left lower lobe, which also did not have very much uptake. But you can see here just how intense the adrenal glands are. So it's coming from somewhere, and it did show up that this lung resection was an atypical carcinoid. And there was also a lymph node that did not have uptake. So they were producing the ACTH, but they did not have the CXCR4 overexpression, which is really very interesting. This is another case of an individual with ACTH independent hypercortisolism. So the pituitary uptake was not there, but you can see it very nicely in the left adrenal mass. And he did go on to adrenalectomy, and it was confirmed to be an adrenal cortical adenoma. In this particular case, this was ACTH dependent hypercortisolism with focal uptake in the pituitary, and you can see corresponding high expression in both adrenal glands. This patient did go to surgery to have a pituitary biopsy, and it also confirmed that there was an adenoma that was a corticotroph adenoma producing excess ACTH. This case of a individual with known Cushing syndrome presented with multiple bilateral adrenal masses, most prominently on the left, as you can see at this arrow, and contrasted to our typical PET scan with FDG, which did not really show robust uptake, a little bit, but not as intense as it was on our Ga-PentixaFor scan. And at surgery showed that this also corresponded to macronodular disease. And with that, I thank you for your attention, and I appreciate the opportunity to talk about Ga-PentixaFor and adrenals.
Thank you so much, Dr. Lindenberg. We do have a question here from someone who had a bilateral adrenalectomy after the discovery of 10 adenomas on each adrenal gland. And they say, I have a suspicion that these growths took many years to develop and caused years of hypercortisolism, leaving me with comorbidities. What have you learned about the growth rate of adrenal adenomas? And is it possible for these to be present for decades in certain cases?
That's a good question, and that probably is better off with our endocrinology colleagues. We're more on the imaging side of things, but as we go along this journey with our protocol, I think we're going to definitely find that there is a level of growth that we'd be surprised is can take a long time. And I think that contributes to also the fact that this is underdiagnosed with the secondary hypertensive issues. If we could get this tracer available to the public in a approved form, this might be something that can be easily accomplished in primary care for ordering it when somebody is coming through with high hypercortisolism or hyperaldosteronism, and they can also be imaged sooner rather than later to discover that maybe there is something else going on besides what they were thinking.
Okay. In a similar vein, and I don't know, maybe you won't be able to answer this, but let's give it a shot. Have there been any tests developed specifically for adrenal rest?
Yeah, I am not going to be able to answer that one since I'm
Okay.
not an endocrinologist, but that sounds like a good one.
Yeah, the question is like a little more elaborate that I'm one of the rare patients who had an adrenal grow back, non-functioning after having both glands removed. And at the time, the scan results, they thought it was cancer. And it wasn't until they removed the lesion that they learned it was adrenal rest. So, kind of a scanning question, which is why I threw it
Yeah.
up there.
So those are good points. The other issue is size as well. So whether it is less than a centimeter, it's going to be a lot, no matter what it is. Whether it is a benign process or a malignant process, it's going to be more difficult to really be able to visualize depending on the expression. So when we think about our PET imaging tools that we have, whether or not you're using a target that's looking at metabolism like FDG, or if you're looking at something that's looking for CXCR4 expression like the Ga-PentixaFor, if there is not a large enough mass, and we don't really know what that mass is. And sometimes it can be really, really small, less than 5 millimeters, but at least greater than 2 millimeters. We're not really sure yet, but sometimes it needs to have just a certain threshold before we're able to actually see that on scanning.
Thank you. Yeah, that's all the questions we had, and we're just about at time, so that was perfect. Really appreciate you being here today, Dr. Lindenberg, and wonderful talk. Thanks,
Thank
everyone. We'll be joining our closing session in 1 minute. Join you there.